I have just my ideas to share, my interpretation from the outside. I'm not a surgeon, but as Edmond says, I'm a physician. I like to think about medicine and decision making. So my thinking is it innovation or just an invention? Because there is a difference between innovation and invention. Innovation is real technology, new technology, something new that makes a difference. So is it innovation or invention? Is it technology or just a toy for surgeons? I know maybe not completely a toy, but if you put it in a spectrum, in one extreme it's just a toy, in other extreme it's a real technology. What is it closer to what spectrum? Okay, in my interpretation, it's a toy. It's not an innovation, it's just an invention. It may become innovation in the future, but that's about research. It's not about shared decision making with a patient. It's not about patient preferences. Patient's preference comes to the table when there is a trade-off. This technology is better in this, but there is a cost to the patient in this. Let's make a decision. I don't see this as a matter of patient values and preference, because if we are really transparent to the patient, we are going to say, I don't know why I'm using this. How about you? There's no dialogue with the patient in these terms.
So I agree with you on some points. I think the truth of the matter is somewhere between what you're saying and what we're saying. I don't think it's fair to say that it's just a toy, because there are definite enhancements in some of the abilities when you use this device, in the sense that the visibility is genuinely better, and the instruments are genuinely better. It's like the difference between using chopsticks and, say, a advanced tool to do the same job. Yes, you can do this job with chopsticks, but there is something to be said with having a more advanced instrument to do the same job, even if the outcome necessarily of the end result is not much different. And I can tell you, for anybody that's done a laparoscopic operation in a difficult spot, like a laparoscopic pelvic operation, it's highly uncomfortable and difficult. And a lot of surgeons end up having all sorts of RSI injuries to their neck because they spend 4 hours a day doing that. And these things are not measured in the trials. So I would say that the truth is somewhere in the middle. Yes, there are unlikely to be patient benefits, but I think there's something in it that's a little bit more than a toy. And the problem is actually in surgical research, because I'm an academic surgeon, but I don't do any research on surgical technique as far as RCTs, because the problem with surgical research is by the time you get as far as the RCT, the ship has sailed. Because unlike, say, drug trials, the requirement to perform an RCT is that a large group of surgeons think an operation is useful first, so there's no equipoise to start, because you're doing these operations on actual patients, and you've got to do a certain number to get to the point where you can even study the thing. And so those surgeons, by the time the RCT is published 5 to 10 years later, they've already done this operation 200 times each. And so it is extremely difficult, after you've become proficient in this craft aspect of it, to then go backwards and do the thing you did 10 years ago. Unlike a drug trial where there isn't much cost to the individual doctor to kind of choose one drug versus another drug. With surgical technique studies, there's a lot of capital in terms of emotional and educational capital that goes into learning the technique. And by the time you've purchased the robot, the robot's in your hospital, that's why you can do the trial. So you've purchased the robot, you've learned how to use it, you've done it 200 times, there's no difference in outcome. So then you're going to start going back to an operation that you forgot how to do, which is an open operation. I think that's the actual problem. I think if it was easy to switch back and forth between robotic and open surgery, there may have been a few surgeons that stopped doing it, but I don't think that's a realistic possibility with surgical technique research. And so you have this situation where the technology is a bit better. It's kind of cool to use. It makes your life better in some ways in terms of visibility and the ease of the operation. there doesn't appear to be much harm, but there's no benefit either. You've already spent the money. How do you go back from that? And the answer is you don't go back from that. And we've seen that over and over again. We saw it with laparoscopic cholecystectomy. We saw it with laparoscopic colectomy. And now we're seeing it with robotic surgery. The march forward does not stop. And I think we're sort of naive to think that somehow we're going to think of it like a drug trial, because it's completely different. And so it's very unlikely that we're going to look at it from that sort of basic rational perspective.
I mean, I think that the 2 points maybe that I think just quickly that came up from that was, one, this idea again about like what outcomes are we optimizing for, and being really clear about it. And it's not a comfortable thing to say we may not be optimizing for a patient's outcome. It may be something else that may be okay, or it may be like so this is a very niche example, but in living donor liver transplant, there's this question of should we be doing living donor liver transplant or living donor kidney transplant, doing the donors robotically. Now, there's surely not going to be any safety benefit because, you know, we know that. But if you can encourage more people to donate, maybe that's an outcome that's okay optimizing for, that the robot may help with. I don't know that for sure. I'm just saying, like, it's just a different outcome. It's not a patient outcome. And so that's an uncomfortable thing to say, like maybe we're optimizing for something that isn't necessarily patient related. That's a discussion for whatever. I think the only other thing I would point out is this may all change in 10 years when everyone coming through training has had lots of exposure to robotics. But right now, you know, it's unpublished, so we have some of this data right now. But basically, there's this idea people are sort of practicing on common, simple operations. I think that's why you're seeing robotic cholecystectomy and hernia repairs really taking off. And there is probably some detriment to patients as people progress on their learning curves or use these operations to practice to do more sophisticated operations where there may be real clinical benefit, like some of the operations that Tarek does in his practice. And so those are real questions that we'll have to figure out, and whether, again, the sort of prevalence of robotics in training fixes that or not. But there is probably some harm to patients as people progress on their learning curve or warm up to doing some of these bigger operations where there may actually be some kind of real benefit.
The reason is that the highest volume prostate surgeons in Australia don't really do open surgery anymore. So really the choice is, in Australia, the choice is surgery, robotic surgery versus radiotherapy or other treatment options. So because open surgery is seen as, I mean, I do a lot of open surgery for pelvic exenturations and things. Open surgery is seen as what you do when you have to do a much bigger operation where you have to remove synchronous organs, generally speaking. For a standard prostate operation, robotic surgery is considered the only surgical option in a lot of places. There's a lot of surgeons that cannot do open prostatectomy anymore because they just haven't trained to do enough.
Let me ask you something, if you guys can try to answer. Why in US or in Sydney, the prostatectomy are not doing laparoscopically? It's a surgeon preference to do robotic? I mean,
speaking for Australia, I would say, and I think it's the same in most places, the urology specialty were very early movers on robotic surgery. And so a lot of them never trained in laparoscopic surgery. So what we have in Australia at the moment is a situation where the people who do the nephrectomy side of things, the abdominal, you know, partial nephrectomy and total nephrectomy, are laparoscopy proficient because they do that with laparoscopic surgery a lot of the time, if not robotic. The people that do pelvic surgery, prostatectomy and cystectomy, they never train to do that laparoscopically. So the training program really went from open to robotic and skipped that middle step.
Yeah, I mean, to Tarek's point, we're doing this study right now where we're trying to figure out whether measured technical skill is rated by an expert is perceived to be better if an operation like a colectomy is done robotically or laparoscopically. And we're having trouble recruiting for the study because people have essentially decided they do them either all laparoscopically or all robotically, and there's very few people who are performing a mix and making that decision on a case-by-case basis. And so to some extent, a lot of this discussion in a frustrating way seems academic because people have already made some of these decisions. And so then we get to this question of what can one do about it? And I think the definition of problems and sort of forcing people to be realistic about what they're optimizing for is one. another option is that right now we're talking about robotic surgery, but we're talking about one company. And so this question of whether new entrants into robotic surgery, either, laparoscopic surgery with some of the technologies of robotics or a new robotic system, whether any competition will sort of meaningfully improve outcomes for patients. And so if there's any way for clinical societies to sort of push that or push, again, for competition in this front, that may be one avenue. I don't necessarily know how, the best way to achieve that, but that may be a very realistic option at this point, because again, I think for some people, the decision has already been.
Yeah. So what you're saying is what behavioral science says. Most of our decisions are not our decisions. It's the system that we are within that makes the decision for you and influence our behavior. The thing is, okay, we are at a point that things are this way, but how about the next technology? Are we learning lessons with this robotic story? For the next thing, we think better how to approach an invention before calling this an innovation. Because I'm learning from you, we are at a point irreversible. But what's our judgment about how the thing processed in these last 10 years?
I think the chance of us not continuing to progress in exactly the same way we have is the same chance as Apple not releasing the next iPhone, which is 0. I'm personally very disillusioned about this idea that in surgical technique research, we can have a nuanced, balanced discussion. Because the march towards improving the technique with whatever the next machine is or the next option is seems almost inevitable. And I learned that from the lap versus open rectal cancer trials. There were 2 large trials done in both sides of the planet, both designed the same way, both trying to answer a specific question. Is lap TME safe? And the answer was no, and nothing changed. So you can't get much better data than that, really, in surgical research. And I think what you'll notice is the opposite. I think what we're starting to notice is the opposite of that, less and less high quality RCTs, because the surgeons that randomized to the RCTs felt that the result made no difference to the eventual outcome. So, I think the impetus, as Kyle said, is not so much on generating data. It's more on entities such as Choosing Wisely or government bodies or whoever the societies are to realize that just because an RCT comes out and it's negative doesn't necessarily mean that that's going to change anything. And so maybe we have to have a completely different approach to how these technologies are analyzed. But will that actually happen? I'm extremely pessimistic about that, if I'm being really honest. I don't think that will happen.
But if I'm going to surgery, I want my surgeon to be better. To be happy, comfortable, not very tired. So I think it can be an outcome to be evaluated. And maybe that's the answer.